Good morning, good afternoon. My name is Jakub Gajewski. I am a research program director at the Institute of Global Surgery in the Royal College of Surgeons in Ireland. And now today I'll be presenting some of our findings on financing surgery in rural settings based on our experience. Gajewski. I am a research program director at the Institute of Global Surgery in the Royal College of Surgeons in Ireland. And now today I'll be presenting some of our findings on financing surgery in rural settings based people globally have no access to safe surgery, and this is primarily in low and middle income countries all over the world. If we look at the sub-Saharan African continent or an African continent, outcomes of surgery are also not great compared to the rest of the world. Twice as
Well, good afternoon, and thank you for the introduction. My name's Andy Bleeden. I work for the ECH Alliance, the Global Health Connector. And we're pleased to take part in today's session on rural healthcare. What I want to try and do is give
ロジェンさん。ロジェンさん。
Yes, yes.
Ah, is there a presenter there? Here? Is there a presenter, speaker?
Not yet. Still we have
Not
some
yet.
time.
Ah, okay. Thank you.
Okay. Good afternoon, everyone. So now, today, we are going to start our rural healthcare session in 58th APAN meeting. So welcome you all. I'm seeing many of our guests as well. To start with Dr. Moriyama, we'll start our introduction. We are here in Kathmandu Model Hospital. We are sharing this rural healthcare session regularly. And nice to see you all in the screen. I would like to ask Dr. Moriyama, so will there be anyone in Pakistan, in host country?
Now I'm in Japan because
Oh,
due to the restriction from our university hospital, we cannot visit to Pakistan this time. So unfortunately, it's totally held online.
oh, okay, okay. So yeah, there is no one in the hosting site, so we'll be the host, I think. And thank you very much. I'm Dr. Uday Koirala, surgeon and also working in telemedicine and rural health for many years. And here we have our team. So please introduce.
Hello, I'm Dr. Asbai Gangwal. Hello, my name is Dr. Adesh Suledi.
Hello, my name is Dr. Dirga Shakir.
Hello, I'm Rosin Sai. Hello, Moriyama.
So you please introduce yourself and tell your name. So starting from Dr. Yang from Korea. Dr. Yang.
Yeah, actually it's true, but doesn't matter.
Yeah, please introduce yourself.
Oh yeah, I'm a heart surgeon working at Samsung Medical Center, Seoul, Korea. But my presentation is actually as a CEO of my company for mental medicine, very, very small company. So thank you so much having me. We enjoyed this session. Thank you.
Thank you. Mr. Chiang.
Hello, this is T. Zhuangjiang from National Taiwan University. It's very glad to join this session. Say hello to everyone from the seashore.
Thank you. Mr. Michael.
Oh, yeah, thank you. Good evening, everyone. Okay, I'm Michael Xu. I'm running a company called CUR Doctor, information service company. And also, I founded a NPO called Wise Love, provide the public service. And glad to meet with everybody and looking forward to hearing from you and learning from you guys. Thank you.
Thank you. Dr. Dennis.
Yes, good afternoon, everyone. No, this is Dr. Dennis Batangan from the Philippines, from the Ateneo de Manila University. Again, congratulations to APAN-58, is it? I think it's APAN-58 now, and thanks to our colleagues from Nepal for always hosting this rural healthcare session. Good day.
Thank you. From Temdek.
This time maybe only I join. Only I join from Temdek. Sorry, it's almost 7:30 p.m.
Oh.
Japan. So that's why
Yes. Okay. So Pawan, Mr. Pawan. Pawan Sake. Fumiko.
Yeah, hello. Hello everyone, I'm Pavan Saka. I'm Vice President of Telemedicine Society of Nepal. I'm sorry I couldn't turn on my video because I'm not in Kathmandu Valley and the place where I am there is no proper network. Thank you.
Thank you. Mr. Rajuli.
Hello everyone. Good afternoon. From Nepal, I'm Rajan Parajuli. I'm the Director of Nepal Research and Education Networks and General Secretary of Telemedicine Society of Nepal. Thank you.
Thank you. Mr. Nirajan.
Hello everyone. I'm Nirajan Parajuli. Thank you so much for this opportunity.
Thank you. Ms. Savina.
Good afternoon, everyone. My name is Sabina Kesi from Kathmandu University, Nepal, and I'm currently pursuing Masters in Health Informatics at Kathmandu University. Thank you.
Thank you. Anyone from QSU? QSU? No. Okay. So now this time our title for the presentation is financing, health financing in rural healthcare. Actually, we wanted to discuss about how this financing can be made possible in rural healthcare, especially in this era of increasing healthcare cost. So Dr. Dennis will start with the presentation, community-based health insurance in the Philippines. Dr. Dennis?
Yes, thank you, Dr. Daya. Can you see my slides?
Yes.
Okay, thank you very much for this invitation. So for this particular session, I will be presenting community-based health insurance in the Philippines to contribute to the topic on health financing on the APAN-58 meeting on rural healthcare. So as earlier mentioned, I'm from the Ateneo de Manila University, working at the School of Social Sciences and the School of Government. In terms of disclosures, I would just like to highlight some of the things that I am involved with, and to include that I have no conflict of interest in this presentation. So the outline of presentation will be three main areas, and I hope to be able to do this in the 10 minutes allocated to me. First, of course, is the health system context in the Philippines to provide an overview of the Philippine healthcare system. Second is healthcare financing, community-based health insurance. And the third will be the role of community-based insurance in universal healthcare. For a brief context, the Philippines is member of the Association of Southeast Asian Nations. There are 10 ASEAN member states, with East Timor as the 11th. But East Timor or Timor-Leste is still an observer status. We have a population of around 110 million in the Philippines, around 7,000 islands in 15 regions in the country. So just to give you a brief context of where we are and the context of the country. In 2019, we implemented, or we approved, the country started implementing the universal healthcare. And as you will see in this slide, the aspiration of universal healthcare is that every Filipino has access to quality, affordable health services when and where they need them, without ever falling into financial hardship when these are served. So health financing is very much part of the universal healthcare implementation in the country. One of the main reform initiatives under universal healthcare is further fiscal and local autonomy through what we call the province-wide and city-wide health systems, which are provisions, actually salient provisions of the universal healthcare in the Philippines. And the aspiration of the universal healthcare implementation in the Philippines is that every Filipino, as you see here, the eligible, the beneficiaries should actually be enrolled in the Philippine Health Insurance Corporation so that they would have access to services provided by the system. What you will see on the left are actually the building blocks of the health system, of which financing, again, is a very, very important component of the building blocks. But what do we have in the Philippines? We have a very fragmented health system, partly because of the decentralization or devolution of health services, and ongoing reforms, which started in 1991 and still continuing on until the moment. And what we have seen also that the Philippine economy, the GDP per capita growth has been growing as well over the years, and the budget, the health sector budget has been growing as well over the years. The figure on the right is what you call the National Expenditure Program in the Philippines, which showed the increasing national government budget to health. But we see as well that the private and out-of-pocket spending has stayed while primary preventive remains the prioritized. The red line you see is actually the insurance contribution to health expenditure. And the yellow line actually is the household out-of-pocket expenditure. So you see a very, very slow decline in the share of current health expenditure from the out-of-pocket expense, which actually we should be expecting with the implementation of universal healthcare. What you see on the right, actually, what is highlighted with the yellow is actually the national health insurance payments to primary healthcare benefits in 2015 to 2020. So you will see a very low, almost zero, share of national health insurance payments to primary healthcare services during those 5 years. So one indicator that we have seen or that we could actually use to assess this is what we call the benefits delivery rate. What you will see here is a part of a study in it looks at the benefits delivery rate is that if you have a target of 100 fully protected Filipinos, data I think around 5 years ago with the Philippine Health Insurance Corporation shows that only 53 are enrolled and eligible to file claims. And out of the 53 that are enrolled and eligible to file claims, only 22 avail of the benefits in accredited hospital. And out of the 22, only 8 actually receive services. So in terms of benefits delivery rate, only 8 Filipinos are fully protected by the National Health Insurance Program prior to the universal healthcare implementation in 2019. So we have still a situation of health inequities. These are indicative of these health status indicators in more advantaged and less disadvantaged provinces in the Philippines. So how does financing come in? What is financing? Health financing is a system for the mobilization, accumulation, allocation of money to cover the health needs of people individually and collectively. In the Philippines, this is through the Philippine Health Insurance Corporation, which looks into the resource mobilization, risk pooling, and resource allocation for the health financing needs of the health system. The objective or the direction, or as far as the framework is concerned, is to generate funds to make the best possible of use funds, and of course financial accessibility for those who need them, primarily the citizens. And the entire Philippine Health or National Health Insurance Program is actually under the concept of social health insurance. So under the social health insurance, the scheme for mobilizing the resources through risk-sharing mechanism that reflects the values of solidarity and shared responsibility for healthcare. What you see at the lower part is actually the basic diagram or relationship between the insurer, the insured, and the healthcare provider. And in this particular case, we are implementing, as far as the Philippine Health Insurance is concerned, a social health insurance concept. So social health insurance is anchored in the concept of solidarity, which is best exemplified in one of the Filipino values called bayanihan. What you see on the right actually is a Filipino artwork by Filipino national artists, which is actually a description of this social solidarity or shared values in terms of helping each other in times of need. So going now more directly in community-based insurance in the Philippines, this actually was enshrined, no, actually highlighted in the Universal Healthcare Law in the Philippines, wherein the goal actually is universal national health insurance coverage and financial protection. However, community-based insurance in the Philippines had a sort of a freeze, no, around the 2010 to 2015 because of the regulatory framework for microinsurance in the Philippines. Now, prior to that, and even at the moment, these community-based insurance are created or are operational at the community level and led by local government units or national non-government organizations, cooperatives, or local institutions. And they operate along shared values and solidarity mechanisms across sectoral concerns. So meaning that this is not purely on health. No, some are actually based on livelihood initiatives, and some are based on sectoral, for example, agricultural related concerns. There are elements of microinsurance, and that was part of the, in a sense, perhaps delay or slowing down of community-based insurance in the Philippines because the regulation under the microinsurance sector or the insurance sector in the Philippines. However, it still has the potential to provide healthcare access to populations that the National Health Insurance Program has problems in reaching, and it can provide additional benefits not covered by health insurance. So community-based insurance in the Philippines arise from communities' recognized need to provide healthcare access to populations not covered by the National Health Insurance Program, like the informal sector workers. So most community-based insurance in the Philippines do not function primarily as health insurance, but rather as an extension or add-on of services offered particularly for their particular sector, like in the case of cooperatives. And communities value the services offered by CBHIs, which complement or add to benefits not covered under PhilHealth. For example, CBHIs can provide transportation expenses for ambulance or travel to hospital, food in the hospital, and other health-related expenses while availing the health services. The additional role of CBHIs in the Philippines under universal healthcare is actually for stakeholding with regards to sectoral representation in local health boards and also national agencies to assist, or to support local public management of the local government units, management of their special health funds, to provide primary care resources, to refine community level and formal primary care provision initiatives, and of course, the primary role of providing additional resources and additional options for resource mobilization for the delivery of services at the community or local level. So with that, I would like to end my presentation in terms of sharing the context of universal healthcare in the Philippines and how community-based health insurance in the Philippines have evolved and is evolving under universal healthcare implementation in the Philippines. Thank you and good day, everyone.
Thank you guys. So it was a very nice presentation and especially elaborating on health financing, which will be very beneficial in the rural parts, I think. So we can have some questions. So is there any question to Dr. Dennis?
May I have a question for Dennis?
Yes.
Yes. Yeah. I just wondering, your health insurance coverage. Suppose your people working in overseas, like my country have many people working in Taiwan. So do they will also get the coverage for the insurance care?
Yeah, thank you for that question. Well, what happens is that if the overseas Filipino workers, for example, Filipinos working overseas, for example, in Taiwan, if they regularly pay their premium contributions to the National Health Insurance Corporate Program, they can actually claim for reimbursement. For example, if they are hospitalized in Taiwan, they would have to pay first, the fees, but they can claim a certain amount for reimbursement from the Philippine Health Insurance Corporation. So at the moment, that is the level of portability that is available. Social health insurance or health insurance portability that's available to members of Philippine Health Insurance Corporation who are overseas workers. Over.
Thank you.
Yes, Dr. Dennis, we also have this two type of scheme. Health insurance that is national coverage. Another is social security. Social security fund is especially for the formal workers, and for informal workers and community, there is health insurance national. But the problem is that people are very much excited when the program comes at first, but when they have to pay every year, then there is decrease in the number they are actually affiliated to the insurance scheme. So what is the response of the community to your program?
Thank you for that, Dr. Daya. So actually, we have a one for the National Health Insurance Program. There is only one scheme, for all the benefits. So whether you are from the public sector, private sector, or even from the indigent sector, you actually enjoy the same benefits. So the fund is pooled, and then there is only one set of benefits for the entire for all the citizens. But of course, that's not always enough. So what happens is that if you can afford, then you could get a private health insurance or an HMO, or the community-based health insurance schemes that I have described. The community-based health insurance schemes are actually locally initiated and locally operated schemes at the local level. So it could actually be a sort of a solidarity fund for anyone, for example, in a member of a group who actually get sick. If you are paying your contributions, then you get a certain amount. It could also be something like a benefit that is provided by a local cooperative or a local organization or a local government, in addition to what you will get from the National Health Insurance benefit from the National Health Insurance Program. So it's some kind of a supplement to what you can get. But not all communities actually have this. Very few communities, very few organizations would have this. And as I said, and as I earlier mentioned, there was actually a regulation, strict regulation from the Insurance Commission a few years back, which actually slowed down the development or the offering of community-based insurance corporations, because the government starting to treat community-based initiatives as regular insurance. So that there was stricter, higher capitalization that was required, which was difficult for a lot of these community groups. Over.
Thank you, Dr. Dennis. So we'll move to next presenter, Michael Su. He will be presenting on establishing a people-centered O2O regional medical care network, the case study of Nantou County, Taiwan. Mr. Michael.
Okay, thank you. Good afternoon, everybody. Please give me a minute, okay, to share my slide. Well, where is my slide? Sorry, my slide disappeared. Wait a minute. Okay.
No problem. So maybe
Okay,
Dr.
it's
Yang,
coming. Okay.
is coming. Yeah.
Yeah, finally. Okay. So can everybody see my slides?
Yes. Yes. Can you make it full screen? Yeah.
Okay, thank you. And firstly, I introduce myself. I'm currently the CEO of a telemedicine company called CUR Doctor. And I'm also a founder of a NPO called Wildlife Alliance. Okay, the NPO is committed to improve the rural health care. Okay, the main mission for the NPO. And today, okay, my honor to share the case of a people-centered regional medical care network, which is a case of in Nantou County in Taiwan. And firstly, I would like to share the financing structure because it is a theme of this seminar. And we work with the government, so that government to manage the service because it's got the public power and the trust. And our NPO Wildlife Alliance will donate some fund and also, and also platform. So the way we to improve the rural health primarily is using the way of digital empowerment, okay, to the local government. And we also seeking funds from enterprise to let them, okay, sponsor some funding to fulfill, okay, their CSR and the ESG, okay, responsibility. So let me give you a quick brief of Nantou County, okay. In this county, 83%, okay, is mountainous. And the 21.5% of the population is over 65 years old. So it is a very typical Asian society. And there are 1.37 doctors per 1,000 people, ranking 18th among the 22 regions in Taiwan. And with 0.6 doctors per square meter, ranking 21st. So you will see, okay, it's even in Taiwan, the medical resource is relatively abundant, but in this county, they are relatively, okay, is shortage of resources. And in this case, we are looking for solved those 5 problems. Number one is health data is spread across various systems. Okay. Second is it's difficult for people in seeking medical treatment. The third is high transportation cost and the time. The fourth is delayed medical care creates more problem. And also detecting disease too late also create more cost. Okay, to provide a solution, okay, we want to build a people-centered health cloud for the government. We sponsor it, donate the platform, okay, which is ISO 27001 certified and also GDPR compliant. And in this architecture, we let government, okay, to connect all the people who require care and also connect the hospitals, clinics, home care agency, and care center. Those institutions, they provide care. And then we provide 4 different services. The first one is interactive video health education. So it's an everyday job, okay? And the second is AI assisted inspection, like the physical examination, ECG, sleep, TB, and bone density. And the third is preventive care. We use AIoT measurement, okay, every day and provide active care, proactive care for those people with abnormal number. And we also invite the family member to join the care. The number 4 is telemedicine. We support the big data, the health data, with AI to those care institution and provide telemedicine doctor consultation, and also it's also enable family member to join the consultation. Here is this solution. In the user side, the APP, we provide an APP, transform the government official website into an interactive O2O service, which can store various health data, such as daily data from care centers. So in Nantou County, those AIoT deployed in 242 community care center, and linked to all the hospitals and the public clinics online for online registration. And so they can do either online consultation or to do the offline treatment. Third is to link to all public free healthcare assistance. The government is the right-hand side. You can see the APP will provide. There are some healthcare service which is free, provided by the government, and also some convenience service. Even you can arrange a public free bus or transportation for you to take you to take the elders to the hospitals. And we also provide for the caregiver APP. The main function is to support the mobility for those caregivers, and also support cross-agency collaboration. So it's a people-centered service. And the last one is the management platform, which supports managing third parties, personnel and staffs. So not only your own organization's personnel, but also including the third parties personnel, which has B2B cooperation with your organization. And we provided the real-time report, including the third-party staff. So, which is a very brief introduction about this case in Nantou. And thank you, and welcome any question.
Thank you very much, Michael. So is there any question to Mr. Michael?
Yeah, thank you for your nice presentation, Michael. And no doubt, Nantou County is a very successful case. Besides that, do you have any other plans go to other place in Taiwan?
Yeah, we have signing cooperation agreement with 3 county, and we are working on the number 4 and the number 5 right now to duplicate the experience and the model to the other counties in Taiwan.
That's wonderful. Thank you very much.
Thank you. Can you please stop sharing so that we can prepare the next one?
Sure. Okay.
Yeah. So yeah, my question to Mr. Michael is, like, with this, this is a very good model of this people-centered medical care. So has it, have you measured about the healthcare cost that it has saved by this model, or will it be more costly, or will it save the cost, healthcare cost?
Yeah, actually, it save a lot of cost for the government and also for the people in Nantou County. Okay, because they can save the transportation cost and improve the accessibility and also the healthcare quality for them through O2O model.
Okay, thank you. Next presentation is by Dr. Jakub Gazewski. He's the Director of Research at RCSI, Institute of Global Surgery. He's a health sociologist with over 20 years of research. Today he was a bit busy and couldn't be present, so he has sent the video of his presentation. We are going to play the video of his presentation. Thank you. The video, can you see the video?
Good morning, good afternoon. My name is Jakub Gajewski. I am a research program director at the Institute of Global Surgery in the Royal College of Surgeons in Ireland. And now today I'll be presenting some of our findings on financing surgery in rural settings based on our experience from Africa. But before I get to tell you more about our findings about financing, I'd like to set the scene about surgical care and ask the question, why should we care about surgical care? Some of you might have heard that the Lancet Commission on Global Surgery have established that 5 billion people globally have no access to safe surgery, and this is primarily in low and middle income countries all over the world. If we look at the sub-Saharan African continent or an African continent, outcomes of surgery are also not great compared to the rest of the world. Twice as many die in Africa after surgery. These are the highlights of a study published in The Lancet recently. Also, at the policy level, surgery must be a core part of healthcare, even in the poorest countries. However, surgery is very poorly prioritized in national government healthcare plans currently. It is also very important to acknowledge that surgically treatable conditions kill more people than tuberculosis, malaria, and HIV/AIDS combined. However, surgery so far has seen little attention from the politicians, from the political establishment. Also, this is not just a phenomenon that is specific to Africa. As you can see from this highlight from an Indian newspaper, India, which is quite representative in the Asian continent. Surgical care in India is also a neglected part of public health, which is similar to many low and middle income countries all over the world. Just to give you a bit of a background about how surgery looks like in sub-Saharan Africa, and what is the population profile of sub-Saharan Africa, 60%, 63% actually of population on the African continent south of Sahara lives in rural areas where district-level hospitals are the main providers of healthcare services. District hospitals are where the people are, which is in the districts in the rural areas of the continent. When it comes to surgical workforce, the situation is very bad. There are only around 1,700 surgeons for a population of nearly 320 million of sub-Saharan Africans. And this equates to half a surgeon per 100,000 people, which is, just to compare it to Ireland, 26 times less than in Ireland. District-level surgery is provided by non-specialists. There are mainly non-physician clinicians or medical doctors with no formal training in surgery. But surgery goes on even without the specialists. Now moving to the cost of surgery, I'd like to say at the beginning upfront, surgery is expensive. We looked at how much surgery costs as a proportion of the total hospital annual budget, and across 3 countries, Malawi, Zambia, and Tanzania, where we worked, surgery and in a district hospital consumes up to 40% of a total annual hospital budget, which is quite a lot. And also, unit cost for surgery is quite expensive, and I'll show you the data very shortly. I would like to also highlight that there is a general underutilization of existing capacity at district level, which has consequences for the cost of surgical services in those facilities. These are some of the papers that I would like to highlight: the cost of providing district level surgery in Malawi, the provision of surgery and scaling up of surgery in Zambia, and also economic cost of provision of the surgical provision in Tanzania, which I'll be sharing the data from. First of all, our study in Malawi have compared 3 district level hospitals in terms of how much does it cost to perform a single surgical procedure in those hospitals. We looked at cesarean section, evacuation from uterus, and hernia procedure, and we have Mangochi, Mulanje, and Sanje district hospitals. And what we can see on this slide, that there is a big difference in price. The prices are in dollars between these hospitals. So a cesarean section in Mangochi is $164, while a cesarean section in Sanje is $638. The difference also is in hernia procedure, $137 versus nearly $600, and evacuation from uterus, $57 in Mangochi, $143, which is nearly 3 times more. The difference is because Sanje underutilizes the surgical capacity, which means that they have the theater, they have the staff, the equipment that to conduct essential surgical basic surgeries. However, they don't do as much as they should be doing to bring the cost down. So every single case that they do is higher because there is a lot of idle time of staff. Mangochi, however, on the other hand side, is a very productive, very efficient hospital. They do quite a lot of surgeries. So the staff's time, which is one of the most expensive cost drivers, is utilized efficiently. Therefore, the cost per procedure is higher. So underutilization of capacity leads to increased cost of surgical provision. Our second study, I think, is very interesting. It compared district level surgical services, the cost in US dollars between district level hospital and a general hospital. We have Mamba District and Livingston General Hospital. And then we can see that in the case of cesarean section, there is a $700, the red column, there's a $700 difference between Mamba and Livingston, $271 difference in the cost between Mamba and Livingston in evacuation of uterus, nearly $600 in a hernia repair. So if we do 10 hernia, if we manage not to refer hernias from a district level hospital to a central hospital, we save $600. Apart from the cost of referrals, we save $600 just in the actual cost of the procedure. So the overall message from the slide is district hospital services are often cheaper for the system than similar surgical services in a general hospital when it comes to essential surgical services. This is also very important to acknowledge. Bringing it again to Asia, I found a study that had similar findings in India. If we look at the cost in rupees of a cesarean section, we can see that the district hospital is significantly cheaper. It's 1,729 rupees per cesarean section than a charitable hospital, which is, I think it equates to a missionary hospital in sub-Saharan Africa, or a private teaching hospital, which has 6,434 rupees per cesarean section, which means, that again, the district hospital services are quite cheap compared to the other ones. We also wanted to look at what are the financial mechanisms for surgery. What do we know about financing surgical services in sub-Saharan Africa? So we conducted a scoping review looking at the different mechanisms and evidence so far. The highlights of this study are that, first of all, there are severe challenges in terms of financing surgical services across sub-Saharan Africa because of constrained fiscal space for health, which translates into there is not enough finance, there is not enough money in the healthcare system to finance surgery adequately. But this is also because there is, like I said at the beginning, poor political prioritization of surgery. Surgery hardly ever appears in the national healthcare strategic plans as a priority. Therefore, there is not there are no dedicated budget lines, particularly in rural settings. I forgot to mention before that at the district level, in the 3 countries where we work, surgery did not have a ring-fence budget line at the district level hospital, which means that the hospital's annual budget as received by a hospital did not have a separate budget for surgical services, yet the cost of surgery was up to 40% of the actual budget. So the resources for surgery were being pulled from other budget lines in the overall hospital annual grant. From our lit review, we've also learned that because there are severe financial shortages, hospitals have difficulties to provide the full service package or to scale up services. They are running at a loss a lot of times, and they are not able to do more because they have no finance for it. And this, in turn, translates into challenges for people to access services. Surgical services are unaffordable for the great majority of populations, and if people access surgery, this often results in a catastrophe and impoverishment because there are no financial protection mechanisms for surgical services in sub-Saharan Africa. Therefore, moving forward, I think what we need to be doing is to there is a need to develop trial studies to identify financial mechanisms for district hospitals, to identify mechanisms that work globally. Maybe during this session, there will be some knowledge to share about what works, what doesn't work. And I think we need to put more research, we need to find out how best to finance surgical services, because in rural settings, because like I said at the beginning, in sub-Saharan Africa, but also in many other low and middle income countries in the world, people are in the districts. They want to be operated on close to home. They want to have services close to home. Yet district hospitals and lower level hospitals, they are not adequately financed, and surgery is not prioritized in those settings. So I think this concludes my presentation. Unfortunately, I cannot be with you. So if you have any questions, please send me an email. Thank you very much for your attention. Enjoy the rest of the session.
Thank you. It was really a nice presentation. Especially being a surgeon, I'm really interested in this financing in global surgery context. So our next presentation will be by Dr. Yang Cho. He is a cardiothoracic surgeon from Samsung Medical Center, Sang Kyung Pang University of Medicine. Dr. Yang.
Hello. Let me
Yes.
share my slide.
Yes.
Okay, thank you for kind introduction. As I told you, I'm working as a cardiac surgeon at Samsung Medical Center, Seoul, Korea. I made my company about two and a half years ago, mainly focusing on kind of telemedicine monitoring in heart failure patients. As a cardiac surgeon, I'm more focused on heart failure surgery, such as transplant, ventricular assist device, venoarterial ECMO, etc. So I came to be interested in heart failure patient, especially quite advanced heart failure. Then, as most of you already know, this is the curve of a clinical course of heart failure. So heart failure, unlike cancer just goes like this, but heart failure quite wax and wane. When this slope down, patients frequently come to emergency room and hospitalized. Sometimes patients just die, cannot recover from their acute episode of heart failure. So this well-known monitoring these patients, telemonitoring, the home monitoring of these patients are quite important, and then have to prevent this kind of acute exacerbation. So I came to be interested in home monitoring of those patients. So quickly, I made my company. I decided to make some kind of device because we have blood pressure measurement device, we have pulse oximetry, we have ECG, we have this type of wearable devices, but all those are not were designed for home monitoring or telemonitoring. So I decided to make a kind of multifunctional printer or a printer which has a fax function and scanner function and printer function, something like that. Not a rocket science. I just decided to design a device having multifunction, as you can see here. So this device has ECG. As you can see, there is a metal lead here and there. There is three lead. And then it also has pulse oximetry, PPG sensor here. Let's turn it on. And then because we have a PPG sensor, we automatically able to know pulse rate or heart rate, whether it comes from ECG or pulse oximetry. And then it has electronic stethoscope. It has a diaphragm here. Then it has a microphone inside so that it kind of able to amplify the sound it can sense from wherever. It can be a heart sound, it can be bowel sound, it can be lung sound, wherever you put it on. And it also has a thermometer, near thermometer here. So, and then the design is checking this vital signs mostly at the same time. So like this, I will show later. You can grab like this. You can put finger here. You can check ECG and PPG at the same time. If you put this on the chest or belly, wherever, it measure the sound where it put it on, and then able to check the skin temperature at the same time, something like that. So this is not well developed yet. I just made the second version of my device. Is there any problem in my? So we are under right now, we are gathering patients' data, especially having a heart failure patient, their ECG and PPG and vital sign, cardiac output, etc. Trying to analyze the big data from the Samsung Medical Center heart failure patients, and then trying to developing AI estimation or prediction of their cardiac output, blood pressure, and then acute exacerbation thing. Still under development. This is not the only device doing that kind of thing. The one, CheckMe Pro, is kind of our prototype, our model, benchmark model. Somebody may already saw this CheckMe Pro. It's a very small kind of patient monitor, having most of the sensor. PPG sensor is here. It also has a ECG lead here and there. It has this thing, and it is able to connect to the blood pressure device, blood pressure medicine device too. And then there's a few more devices called HytoCare and none of them. This is from Israel, this is from US. Withings, you probably you all know this brand name of Withings, mainly making this wearable watch, but they made it this kind of bar thing, able to check ECG and PPG, etc. So our one is more flexible, designed to be flexible, has both Bluetooth and Wi-Fi, and then able to work independently without smartphone like this. So as you can see, with this one and non-Agon one, it is essential you have a smartphone plus app. But my one just able to work independently. But thing is still under development. So I just skip this. AIM is kind of able to triage patient, whether patient is critical condition or it's just we can be observed this patient, etc. So this is usability comparison, as I showed before. This is AI prediction, what we are currently doing. We are gathering heart failure patient ECG and PPG blood pressure and cardiac output from Soangans thermodilution and trying to estimate from ECG or PPG of their cardiac output. Still under development. So detailed design of my device. And this is what we are using. Grab like this. As you can see, PPG sensor automatically activated. Still, filter is not very good. As you can see, kind of ECG is coming out. You can see the pulse. So let me conclude. What is our plan? So we need to further develop. This is second version of experimental model of our device. We have just this device. We actually, for the first version, we developed a system for healthcare professionals able to see and gathering patient data from this device to the cloud, Amazon cloud. But for the second version, we because short of money, we just made this device. And we have to develop early warning system using AI and other mathematical model. And we also have to need to mass production of this. We will use 3D printing in order to make many devices in a lower cost. And then this is something I get to hear. Looking for a test bed. I think Nepal and other South Asian country is should be perfect test bed for our device. And then we're gonna use this device in my hospital and then other tertiary Korean hospital as well. And then as I mentioned, we short of money. I really want to get money from Koika or Korean venture capitals. Thank you very much.
Thank you, Dr. Yan. So it was really a nice presentation, and this device, I think it will be very useful, especially for remote monitoring. And for the country like Nepal, it would be very much beneficial. So hope we can have further program for this. Is there any question for Dr. Yang? So if there is no question, then we'd like to move forward. There is another presentation from Andy Bladen. He is Communities Director from ECH Alliance in the Global Health Connector. He is trying to establish a ecosystem, digital health ecosystem, and we have been working together. He's from UK, England, and today also he couldn't be present and has sent this recorded video. Now we are going to play that.
Well, good afternoon, and thank you for the introduction. My name's Andy Bleeden. I work for the ECH Alliance, the Global Health Connector. And we're pleased to take part in today's session on rural healthcare. What I want to try and do is give a little bit of an insight about who we are, but also give some practical examples where across our network, we see successful adoption and implementation of rural healthcare. Just for those people who don't know who we are, I'll share a couple of just pieces of information with you, which hopefully will give you an idea about the type of network we've got, but also where that network is and how you can get involved. So as the Global Health Connector, ECH Alliance have been, since 2012, building up a network of over 1,100 organizations across the globe. And we bring those together in a network of 80 different ecosystems, okay, in different locations. And some of them you'll be aware of, some of them you won't be. And the idea behind that is based on an idea that in healthcare, we've got this particular two problems. One is that healthcare, unlike finance or fintech, etc., which are global, healthcare is kind of national, and everything has to be reinvented from nation to nation, sometimes from region to region as well. And because of that, we've got this particular problem of trying to reinvent the wheel. And healthcare is also very, very siloed. So there's many, many silos in healthcare, which I'm sure you're all part of in your countries as well. And no one country holds a moral mandate on this. So it's as bad as in the UK where I used to work, as it is in, say, Australia or the US or across the African continent. So we bring our members together in these ecosystems to do four things. We connect them, we can bring them together, we amplify what they do, and we accelerate what our members do. You'll see my contacts down here where you can contact me if you want to reach out and find out more about that. But just so I want to touch with you so you understand what we mean by ecosystems, because a lot of people write a lot of stuff about ecosystems, certainly academics. Don't wish to offend anyone here. But for us, it's quite a basic concept, because ecosystems are there to match need and solution. They bring all the stakeholders together of health together in what we call permanent multi-stakeholder gatherings on topics that are decided by the local ecosystem or the national ecosystem as being a priority. And then use an idea where we bring first the need and then the solution and see where we can collaborate. So that might be on a topic like diabetes, and we bring along the need for patient organizations who want to understand what solutions and services are there for people with recent diagnosis of type 2 diabetes, for instance. Healthcare professionals in terms of information they need or solutions or services, as well as companies wanting to understand more, policymakers who might need to understand trends, and researchers who need to have access to data. They all are permanently wonderful organizations, of course, but they work in silos. And very, very rarely do they collaborate and communicate to each other. So we bring those need organizations together. And then we flip it on its head and say, okay, well, what does good look like in this country, in this region? Where's their best practice, best pieces of research, decent policies, peer education programs, etc. Again, all of those organizations, very laudable, but very often work in silos. So we bring those together and then connect them with the need to break down silos, transform healthcare delivery. And by that, I mean actually do stuff as opposed to talking about doing stuff. But also because healthcare is such a large area of spend, to create economic growth. So we've developed a network of these ecosystems across all the countries you can see here. We're rapidly expanding in the US now and also in Africa, building up a network of ecosystems across the whole of the continent of Africa with partners from Africa's CDC. And we're looking to expand that network. So if you're interested in finding out more about that, please also connect with us. Because this network is vital because it's both an implementation network, okay, for getting things done across the globe, but also as an intelligence network So we've got connections there in the ground, on the ground, real connections, whether it's in Slovenia, or for instance in Chile or Croatia or Turkey, who can have that vital role in making connections where you might be wanting to do collaborative pieces of work. We also bring those coordinators together of all these ecosystems and see where we can collaborate better, whether it's in projects, whether that's in the EU, the US, Africa, etc., or indeed on further areas of collaboration. We've also established a series of thematic ecosystems which are cross-border in nature and cover such areas as cancer or women's health. Recently, we've been exploring the area of rural health as part of our ecosystem on digital health data, which is vital to understand how different countries target those people that are hardest to reach, either physically or politically. Two different necessarily reasons, but also quite important. So for instance, on the topic of cancer, we've been able to bring best practice from Latin America, US, Europe, the WHO, Africa, and also Turkey. I mention Africa and Turkey because very often we see a very westernized approach to cancer care. But within Africa, we could showcase best practice around state-led public health measures that would leave many in Europe absolutely amazed by the impact of those public health programs and at a fraction of the cost of some of our failed health programs. So that's an example of how we work. We're also getting involved with a number of global events. So we're going to be at Health, HLTH in Las Vegas. If you're interested in finding out more about that, scan that code on the screen with your phones now. We're building a global village there as part of the largest health ecosystem session across the whole of the US. Brilliant organization, and find out more using that link and get involved and contact with me. You can also subscribe to our newsletter, it's free. And if you're interested, you can also become a member to scan the code on the right here. Use these because this is how you can get involved with our network and hopefully find out more about how to connect up with those other ecosystems. So that's enough about us. Let's go back to talk about how we work with some of those different countries around the area of rural health, and particularly areas of finance, because finance is the missing key that helps with the delivery of rural healthcare. And I'll give you 3 examples. And if I've got time, luckily, maybe a 4th one as well. So we've brought together, for instance, within Spain, we've got a unique ecosystem that tackles the area of rural healthcare, whether it's adult social care or mental health care or dealing with dementia, but particularly in a very rural and remote region within Spain. That's a very good example of where the state or the region has taken a lead role in financing and delivering rural healthcare. And if you're interested in finding out more about that, contact me, andy@echalliance.com, and we'll connect you up with our ecosystem network in Spain to find out more about how that's delivered. Particularly the work they've done around working with older people, as many of the younger people have exited that region to move to the cities. It's become depopulated and also very much more remote as many of the transport links have gone that came with that larger population. And what we've been able to do is connect up that ecosystem with other rural ecosystems, whether it's in Greece or perhaps in Bulgaria and Romania, to see how they approach the issue of dealing around financing rural healthcare, whether that's using money from the recently released regeneration and renewal funds from the European Commission, or indeed bending some of that mainstream funding from local government to target their most remote and hard to reach. Because very often in those communities, that population actually costs the most. Because what happens then is they are the least to get access to primary care, the least to get transitional care that's consistent, and they're more likely to turn up at the more expensive end of healthcare. So it's in the region's interest to maintain their position in the community and keep them out of formal healthcare for as long as possible. So the finance cost, if they don't, is really prohibitive. So it's much cheaper to invest further in the front of the program to prevent further costs further down the line. So that's an example from Spain, and a brilliant organization, Fundesalud, has been leading on that piece of work. And if you're interested, I've got a recording of one of the ecosystems we've done on that, which is in English, so it's all the participants spoke in English. Second, I want to then move across the globe and talk about some of the work where our ecosystems are working in Zimbabwe. So in Zimbabwe, the need there is for the delivery of remote hospital care in areas that are physically hard to get to and physically hard to develop and build what we would class as the built hospital environment. So much of this hospital provision has to be delivered remotely because there is no first option. The delivery isn't there elsewhere. So we're working with our Zimbabwean ecosystem who are looking for both solutions, funders, and investments from outside and within Africa to get involved with Zimbabwe and seek to deliver the delivery of new remote hospital provision using the best methodologies. And they've approached and worked with colleagues from, say, Norway or the US for some collaborative work there, but also, most importantly, from across Africa. Because Africa, as we know, is a very, very large continent, and there's a lot of progressive work around rural and remote healthcare actually being delivered. Because in Africa, what we find within our network is there's a much easier approach to public-private partnership that we don't see as often in some of our other networks. And then the third example I want to give you, because I want to make time for all our speakers today, is to look at the rural and remote healthcare delivered in Scotland. So in Scotland, obviously, it's a small country within the UK, but a lot of that population live in relatively remote and rural areas that have been traditionally too far away from mainstream healthcare provision because they're either separated by a large landmass or indeed by a sea barrier. So there are many highland areas that are hard to reach and to get to, and also islands off of Scotland and some significant distance away from Scotland, which if you become ill, you need to get access to healthcare in an emergency, can mean rapid transport, either via helicopter, which is very, very expensive, or indeed using traditional services such as ferries and buses and rail, which can add days to journey times for people accessing hospital treatment. So in Scotland, they rolled out a very successful program called NHS Near Me, using one of our members' solutions, which is a video consultation service, before the pandemic, to understand how we could best deliver healthcare in remote communities, but without the cost of building new facilities. So they've undertaken a number of different activities using video consultation in small rural locations that allow people to access hospital triage services, hospital consultations via video, using perhaps the local post office or the local pub or a church building, and get access to consultants, access to that first level of what I would class as healthcare, but without the distance and without the travelling involved, which enables them both to save their own time and money in travelling, but also means that hospital clinicians can see more patients more rapidly during that pace of the day. Now that program's been rolled out nationally through the pandemic, and after the pandemic has stayed there because the cost savings there are enormous. And we've seen successful programs like that across Scotland, but also with radiology provision across Scotland as well, delivered again in some of the Highlands and Islands areas that traditionally would never have access to the ability to be able to provide radiology because of cost and the barriers to that. So some really good examples there within Scotland. Again, want to find out about them or our ecosystem in Zimbabwe, or indeed our ecosystem or some of our ecosystems in Spain, get in touch with me. More importantly, I always think about this and I'll leave you with this thought. There's the so what bit. What does this mean for us? Whether you're perhaps there in Islamabad or in Nepal, I know we've got colleagues from Nepal there. What does this mean for us in terms of collaboration? How can we get involved with this? Well, I'm looking to build a network of thematic ecosystems all the time. I'm always looking for best practice from other regions. So if you've got successful practice in this area around rural healthcare, and particularly the financing, let me know, because we can share that with other countries. That's important because, for goodness sake, we've got to stop reinventing the wheel and get back to doing healthcare as opposed to talking about healthcare. Okay, I'm going to pass you back. Hopefully you've caught up some time from the people who've overrun before, and I hope you enjoy the rest of the programme. My name's Andy Bleaton. Don't forget you can reach out to me at andy@echalliance.com or contact Udaya here, who will give you my contact directly. Thank you very much. Look forward to speaking to you.
Thank you, Dr. Andy. So it was very nice presentation. And with that, we are concluding the presentations. But here are some important persons that we'd like to hear from. Mr. Chiang Chichuan from Taiwan. So we'd like to hear from you some of your insights in health financing.
Sorry, Dr. Udaya, I'm driving, so I'm not convenient to talk too much. Sorry. But
okay.
I'm very pleased to join this session and looking forward to meet you all in the future online, on site, in person.
Okay, thank you, Dr. Chang, for participating. Here is Dr. Moriyama. So please put on your view about the health financing.
Thank you for organizing this very quite interesting session. So the health insurance system is quite complicated in each country, same in Japan actually. So, but without financing, we can do nothing actually as a medication. So it's a quite a big issue for each country, and also each country have their various programs also. So that's why we should think about more and more to save the patient, especially in rural area. So thank you for organizing interesting sessions. Thank you.
Thank you, Dr. Moriyama. Here is Dr. Rajan Parazuli from Nepal Research and Education Network and Telemedicine Society. Dr. Rajan.
Okay, thank you, Uday sir. Yes, regarding the health financing, yeah, it is a very important component, and we need to have a different approaches for this when delivering healthcare services in rural areas, as well as there is a disparities between urban areas and rural areas. So I think we need to consider these rural sectors as from the different perspectives. I think yeah, that's the thing I want to tell. So nothing much. Thank you for this wonderful sessions and your all the efforts to make it very successful. Thank you.
Thank you, Dr. Rajan. Mr. Pawan Sakhi from ICT 4D and Telemedicine Society. Mr. Pawan.
Yeah, thank you, Dr. Dekoyara. We had a wonderful session. I think, as the previous speaker said, health financing scheme is obviously very much a challenge in country like ours, especially in the rural area. But I think like with the effective collaboration with international and national partners, we can achieve a few steps in terms of providing effective and affordable healthcare services in the rural areas. Thank you so much, sir.
Thank you. Thank you. So is there any question to any presenter? If you have any queries or comments, please, you can share. Yes. If not, then with Mr. Michael. Mr. Michael, do you know about this Truchi Foundation in Taiwan?
You mean what? I beg your pardon?
There is a foundation called Truchi Foundation.
Chiji Foundation. Yes.
Yeah.
We are also working with their hospitals, okay, in the county, in one of the county. I'm right now signing the cooperation agreement with the government.
Because they are really interested to work in healthcare in Nepal. So there are some people from Truchi Foundation. Is it
Yes.
Chichi or Truchi? Yeah. Because we call Truchi. so I didn't know how to pronounce. But they are actually interested to work in rural parts of Nepal. So maybe we can have connection with that foundation.
Yeah.
So if you have connection, please we can suggest. And with that, if anyone doesn't have any comments, we can end the session. And thank you all for making it a very successful session. Hope to see you in the next APAN meeting.
Okay. Thank you.
Thank you very much.
Thank you very much. Next one will be held in Tokyo. See you in Japan.
Oh, okay. Yeah, see you.
Thank you, everyone.
Thank you.